Assalamu alaikum everyone, and welcome to the webinar number 4 of our HIV awareness, prevention and education project in Pakistan. And this project is jointly designed and led by APPNA-MERIT HIV Committee in partnership with the Common Management Unit, HIV, TB, Malaria, Government of Pakistan, and the Medical Microbiology and Infectious Diseases Society of Pakistan. I would like to introduce our moderator for today. He is Dr. Muzammal Habib. Dr. Habib graduated from the Punjab Medical College, University of Punjab in 1997. Currently, he works in Massachusetts, USA, and is affiliated with Lowell General Hospital and St. Elizabeth Hospital in Boston, Massachusetts. He is board certified in vascular medicine and internal medicine with real passion for vascular medicine and cardiology. He is continually active in his professional life, highly accomplished, and is considered a leader in his field. He is a fellow with Society for Vascular Medicine and is an active member of Society for Vascular Ultrasound, American Heart Association, Massachusetts Medical Society, and APPNA, which is a New England chapter of APPNA. And welcome, Dr. Habib. So please take over from here.
Thank you very much, Dr. Gilani. Thank you for a wonderful introduction. I think it was more than what I deserved, but thank you for APPNA-MERIT and whole team working so hard to bring all those webinars together. It's not easy, and probably we can understand how much hard work it takes. We are lucky to have a wonderful panel today of presenters from all corners of United States. Unfortunately, our presenter from Pakistan had to drop out today because of family emergency. So I will start with Dr. Aadia I Rana. I hope I'm calling her first name right. She is an associate professor of medicine at University of Alabama, Birmingham, and she is associate scientist with UAB Center for AIDS Research. She is NIH-funded researcher, and her research focuses on disparities in access and adherence to medical treatment among people living with HIV, outcomes of women living with HIV, and implementations of combined biomedical and behavioral interventions to improve the treatment adherence in US and also globally. She has also served as a site principal investigator on HIV and hepatitis C therapeutics and clinical trials. Her work incorporates health services, research, behavioral sciences, social sciences, and clinical medicine. Dr. Rana, if you could kindly start your presentation. So I will share my screen with your slides.
And I'll just ask you to advance, is that?
That's completely fine.
Okay.
Please, just a minute, sorry. Please let me know if you can see my screen.
Yes, I can see your screen. Thank you.
Wonderful. So it should be
full screen now. Yep.
Full screen. Okay.
Yes. Okay, great. Thank you. And thank you to APPNA-MERIT, the organizers, particularly to Dr. Gilani for all of the effort that she's put in to get us all to get together for these seminars and organize. So really appreciate everybody's effort in doing that. So I'm just going to be talking for a little less than half an hour on management of HIV Hep C co-infection. And I would say that if I were going to highlight 2 or 3 takeaway points from this entire lecture, I think the main things to remember are: 1, anytime you have a patient with HIV, you need to know their hepatitis C status. Number 2, Hep C is eminently treatable and actually quite easily treatable, so don't hesitate to treat it. And number 3, it's going to take an all hands on deck approach to eliminate hepatitis C, but we have the tools to do it, whether we're in the US or we're in Pakistan. So I think those are the things we have to keep sort of in the forefront of our minds. So next slide, please. So viral hepatitis C around the world. So the Center for Disease Analysis estimates that South Asia and Asia has the highest rates of Hep C in the world in terms of prevalence, with the highest being in China, about 10 million people living with Hep C. But the second country, as you all may know, is actually Pakistan, estimated about a little over 7 million people living with HIV, and then India and Egypt. And these 4 countries actually account for almost 40% of people living with HIV. Next slide. And there's a big gap between infection and treatment. So when you look at the proportion of people who are infected, you see that there is a significant drop off even from the infected to diagnosed. So there are a lot of people who are unaware of their Hep C status. So that's an tremendous gap that needs to be overcome. And then when you look at the proportion who have been successfully treated, we have a significant drop off. So a long way to go to elimination of this virus. But again, I'll emphasize that we do have the tools in order to do this. Next slide, please. So now, as for the talk, we're talking about HIV Hep C co-infection. And to sort of crystallize that particular epidemic. So we have a little over almost 37 million people living with HIV globally. But of those, over 2 million have past or present Hep C infection. And among people living with HIV, the prevalence of Hep C is highest in people who have injected drugs. So about 82% of the people who have HIV Hep C co-infection either are currently or have a history of injection drug use. And that's followed by men who have sex with men and pregnant women. Studies have shown that there are very high rates among prisoners, so people who are in jail or incarcerated in prisons living with HIV, though less data has been collected in that particular population, as you can imagine. But again, it's important to test all people living with HIV for hepatitis C. Next slide. And this is why it's important. So we looked at this disease progression of hepatitis C and compared it in patients who only have hepatitis C, have hepatitis C and HIV, and have not been on effective treatment for HIV, but also those who are HIV Hep C co-infected and have been treated with effective therapy. And as you can see, when you look at the overall cumulative incidence of hepatic decompensation, the highest rates is among people who are co-infected who did not get effective HIV therapy, when you compared to those who are mono-infected. And similarly, you see that same pattern in HIV Hep C co-infection for time to decompensation. But the one thing you may notice is this line of separation between HIV for the co-infected patients, between those who are effectively treated and who are not effectively treated, is not that broad. So really speaks to the need for treatment of hepatitis C as well. Next slide. The other thing to note is that there's no decline in end-stage liver disease incidence in people with co-infection when we look at the modern ART era. Now, this is, again, before the implementation of, or massive implementation of direct-acting agents. But as you can see, when you look at what was the incidence of end-stage liver disease in persons years, when we compare early ART to middle ART to modern ART era as defined on this slide, we don't see that statistically significant of a decline. So again, emphasizing the importance of treating. Next slide, please. And the good news is the direct acting agents do have similar efficacy in persons both with and without HIV co-infection. So this was aggregate report of people who are across phase 3 studies of genotype 1 through 6 hep C co-infection with a variety of the direct acting agents. And as you can see, sustained virologic response is extremely high, whether you're talking about mono-infection or co-infection. So really no reason not to use the direct acting agents in a co-infected population. Next slide. And it's very interesting because the hep C direct acting agents target the steps of the hep C life cycle, very similar to the way HIV drugs target the HIV life cycle. This is why, as an infectious disease physician, as an HIV physician, we were over the moon about the direct acting agents in our clinic, because a lot of them, especially when you have a class like protease inhibitors, who knows better how to treat people with protease inhibitors than infectious disease doctors? And it made it very easy for us to think all of these people that we had previously had to potentially send to GI or hepatology for interferon or ribavirin. Instead, we could very simply, just like we prescribe their ARTs, we could prescribe and manage and take care of our patients, which often would be easier because, having all of your care in the same place certainly is supportive and helping patients to get the care quickly that they need. So, so in terms of the 3 major classes of direct acting agents, so there are those protease inhibitors. These names are so long and they're so complicated, I cannot pronounce most of them either. And so I usually just use the abbreviations or the trade names. But, if it's a protease inhibitor, the name ends in Previr. If it's a NS5B polymerase inhibitor, the name ends in Buvir, and then NS5A, it's Asvir. So some method to their madness, but I just wanted to show that to you all. Next slide, please. So these are the the Society for Liver Disease in the US and the Infectious Disease Society of America recommendations for first-line hep C treatment in hep C HIV co-infection. And I think the main thing to recognize here is that sofosbuvir, valpitasvir are pretty common among whether you don't have cirrhosis, whether you have cirrhosis, and then the only caveat is renal function. So you may need to reach for a different direct acting agent depending on the renal function. But the other thing I want to emphasize is look at the duration of weeks. So even in HIV hep C co-infection, the duration of therapy is between 8 to 12 weeks. So between 2 to 3 months, and you can cure relatively quickly. And so this is, for those of us who remember the interferon gamma ribavirin days, a very different paradigm, and we didn't know that we would be able to get here. So really great. Next slide. So comparing that to the World Health Organization HIV treatment guidelines, which aren't as detailed, so certainly refer back to all of these guidelines. HCV treatment guidelines are available on the web. I'm sorry, these are the HIV treatment guidelines. So the first for first-line ART regimens is dolutegravir combined with an NRTI backbone. Actually, can you go to the next slide? I'm sorry, I think. And maybe one more slide. Sorry, yes, I'm sorry, these are out of order. So the World Health Organization hep C treatment guidelines are basically fairly simple, as I mentioned. So basically they recommend any pan-genotypic regimen available for adults 18 years and older, and they have a slight difference between whether they have cirrhosis or not cirrhosis. And so these are the recommendations for that. And then, I'm sorry, can you just go back 2 slides? And then just to go over HIV treatment guidelines by the WHO. Again, dolutegravir with an NRTI backbone, so those are nucleoside reverse transcriptase inhibitors, is the regimen that's now being incorporated all around the world, also known as TLD. And then alternatively efavirenz, or another, the other agent is raltegravir, which is also an integrase inhibitor. Next slide. And similarly, in the United States, integrase inhibitors, which is a class of HIV drugs, I think that you have reviewed on your prior seminars, are really the first line agents in the US, mostly related to the fact that they are very well tolerated, extremely effective, and have very few drug-drug interactions. Next slide, and next slide. So co-treatment of Hep C and HIV infection. So you see your patient, they come in, what's the first thing you're going to do for a person living with HIV? Again, you're gonna check a variety of lab work on this patient, but you are also gonna check their Hep C status. And so you're gonna check a Hep C antibody, and of course, if it's positive, you're going to check a viral load, or also known as a RNA level. And if it's detectable, you want to reevaluate and see if it's sustained. Then you can go on to evaluating for the need for direct acting agents. So first you get a Hep C genotype, because you need to know what genotype it is. You'll need to stage the liver disease. The child Pew score, as you guys may remember from your training, as well as the need for an endoscopy based on their clinical presentation, and then consideration for cancer screening. So that includes like an ultrasound, for example. Have they been treated before? It's very important to consider also to know what their hepatitis B status is as well. If you're doing HIV, when you do HIV workup, if you're starting or switching ART at the same time, you will need an RNA level. I don't think this is as relevant to you all because I don't know how much abacavir you all use to treat HIV, but HLA-B5701 status, CD4 count, and resistance testing. And then all patients will need to have their creatinine clearance. You'll need to know what other medications they're taking, non-HIV, non-direct acting agents. Definitely ask about any herbal or over-the-counter medications they are taking, and then a consideration for their comorbidities. Next slide. So some of the things that we think about, some common scenarios that I will see in my clinic. So there's you can have a person who's taking ART with HIV RNA suppression who plans to initiate these direct acting agents. So your major decision point as a provider at that juncture is, what is the selection of the Hep C DAA regimen? And number two, do you need to maybe adjust your antiretroviral therapy? Do you to facilitate a very specific direct acting agent regimen, based on their genotype or other or renal or kidney function or whatever it might be? So that's one sort of potential scenario. The second scenario is you see your patient, they're not taking ART, but they also do need to initiate Hep C treatment. And so your question there is, well, what should I do first? Should I start their HIV treatment? Should I go ahead and, they're here, I only need to give them 8 weeks of Hep C treatment. What should I do at that point? Next slide. So let's go over those cases. So a stable, you have a gentleman, 58-year-old man, he has HIV and he has chronic Hep C infection. So he is stable on his regimen of atazanavir, ritonavir. So that's a boosted protease inhibitor regimen. And he's on 3-TC and TDF. So those are his nucleoside backbone. His viral load is excellent, excellent control, less than 20 copies. And his CD4 cell count is 800, essentially a normal functioning immune system. And his HLA-B5701, which is a marker that we check to see for abacavir hypersensitivity, is negative. So we know that if we need to, we can switch him to abacavir. When we look at his Hep C, he's treatment naive, he's genotype 1A. He has a very high Hep C viral load, which is common when we see untreated Hep C of over 1 million units. He has some evidence of liver stiffness on elastography as F2, but his GFR is good. He has a clearance of about 65, and we have appropriately checked his hepatitis B status, and he is hepatitis B negative. Next slide. And so when we think about his regimen, so he's on a protease inhibitor regimen. And the challenge with protease inhibitor regimens, and that's listed in the first two columns here, atazanavir and darunavir, the first two, and then they're boosted with additional protease inhibitors. There are contraindications to using a lot of the pangenotypic agents with those protease inhibitors. So in general, if somebody is on a protease inhibitor regimen, which I know in Pakistan is probably not that common since it's considered second or third line agent, that you may need to switch that patient off of protease inhibitor and start them either on an integrase inhibitor or a non-nucleoside reverse transcriptase inhibitor like efavirenz. The good news is when you look at the most commonly, some of the most commonly prescribed Hep C agents, they are actually fairly well tolerated across all antiretroviral regimens. So this is a good sort of pocket table to have in mind when you're considering your patient. So I would say here in Pakistan, we're thinking more about efavirenz or dolutegravir or raltegravir, and you're in pretty good shape for most of them. Efavirenz, you're really restricted to having sofosbuvir and ledipasvir. Next slide. Yeah, so co-administration of Hep C and HIV protease inhibitors are currently not recommended. Next slide. And the other point is co-administration of these two agents with tenofovir TDF, but not tenofovir alafenamide, requires liver monitoring. So if you're using TDF, which is what you'll probably be using, then you will need periodic liver monitoring. But again, for a very short amount of time, we're talking about between 8 and 12 weeks. Next slide. So when you do have, so you have this gentleman on the protease inhibitor and you want to switch him, what do you have to think about? You need to review his history. You need to review his history. Does he have any previous intolerance to the regimen that you would like to switch him to? Review any resistance. If you're unsure, consider a switch only if the new regimen is likely to maintain suppression of the resistant virus. This gentleman does not have hepatitis B, but if he did have hepatitis B, you need to take that into consideration because you need to continue to treat the hepatitis B even while you're treating the Hep C. So that means make sure that you are continuing either tenofovir alafenamide or TDF plus 3TC or FTC. And I would say you check your HIV-1 RNA after the switch at least 1 or 2 times during the first 3 months to ensure that suppression is maintained. We do not recommend switching them to monotherapy just to accommodate the Hep C treatment with either a boosted PI or INSTI. What people will often do is they will switch their ART and then monitor them for about 4 weeks to make sure that ART is tolerated and effective, and then initiate the Hep C direct acting agents. Next slide. And so this is a study looking at soft LDV and HIV Hep C co-infection patients after a switch to a TAF regimen. So what we had were people with HIV, stable, less than 50 copies of their RNA. They had good renal function, and they had genotype 1 infection and no history of resistance to any of the Hep C agents. And so these people were either switched to a boosted integrase inhibitor regimen or switched to rilpivirine, which is like efavirenz, a non-nucleoside reverse transcriptase inhibitor. And then they were started on soft/LDV. And as you can see, still very, very high rates of viral suppression, maintained cure at 12 weeks. So you do continue to maintain that efficacy even with the switch. Next slide. And again, just another couple of studies looking at what happens with switching ART. Some suggestion in the slide, in the image on the left, that changing ART may have some element of decreased response in Hep C. And then another slide looking at patients who were switched found no difference. So it's really just going to come down to your I think individual patient and experience as to how how you want to approach. Next slide. Always consider the potential for Hep B reactivation. So again, test all patients initiating Hep C direct acting agents for Hep B surface antigen, anti-Hep B core antibody, and anti-Hep B surface antibody. I will re-emphasize HIV infected patients who do have Hep B infection active, meaning their antigen is positive, should always receive dual NRTI therapy with anti-Hep B activity. And just certainly in those patients, you do want to initiate ART before direct acting therapy owing to the risk of Hep B reactivation with the direct acting agents. It's a little unclear what to do with patients who have evidence of prior exposure. So their core antibody is positive, but maybe they don't have evidence of surface antibody positivity, which usually means immune, or maybe they do. There's really no consensus on what to do in those cases. Do they have an increased risk of reactivation? We consider it low, but we do recommend monitoring transaminases at weeks 4 and 8 following Hep C treatment initiation. There's really insufficient data to say, you know what, you need to bring these patients in regularly for Hep B DNA monitoring. Next slide. So now let's talk about co-treatment of both HIV and Hep C infection. So you have a 38-year-old man with HIV and Hep C infection, and he was out of care, and now he's come back to reestablish care. He tells you he has a history of injection drug use, but now he's living in a program, and he's getting medication-assisted therapy. So he is getting treatment for his substance addiction. And he also has good renal function with the eGFR of 55 milliliters per minute. So with regards to his HIV, he is previously out of care. His previous HIV treatment is with efavirenz, tenofovir, and FTC. His T cell count is slightly lower, 385, and his viral load is 54,000. HLA is B5701 is negative. His Hep C status, so he is genotype 3A with a high viral load, and he does have elastography. His imaging is actually more consistent with fibrosis, and his Hep B status is negative. Next slide.
Dr. Rana, we are really enjoying your presentation, but as a friendly reminder, last 3 minutes, please.
Okay, sounds good. I think we should be done pretty soon.
Thank you.
And so for this gentleman in slide for genotype 3, these are the recommendations with regards to HIV Hep C co-infection. So either you still have options of 8 or 12 weeks. He doesn't have cirrhosis, so you could probably stick with the first column here. Next slide. So for many patients, initiation of ART should be prioritized. However, HIV treatment and HIV RNA suppression are not absolute requirements for before you start Hep C treatment. So treatment readiness for 8 to 12 weeks of just therapy, just some course, is very different than treatment readiness for, hey, are you ready to commit for lifelong treatment? And there's no question that Hep C treatment and cure may be the way to get people who are out of care in to care, to facilitate care engagement. And certainly sustained a virologic response will reduce the risk for drug-induced liver injury. And if ART is initiated first, consider delaying the Hep C treatment for 4 to 6 weeks, just so you can make sure that they tolerate the therapy. Next slide. So just a common list of drug-drug interactions that you need to think about for ART and non-DAAs. Next slide. And again, to emphasize that Hep C care does continue past the achievement of sustained virologic response, because when you think about it, some of the behaviors that put these individuals at risk for HIV and at risk for Hep C might continue. So if they have a history of injection drug use or other risk factors that put them at risk for Hep C, once you're cured, you can be reinfected. And so you want to continue to emphasize and keep them engaged with care for counseling, harm reduction, those sorts of things, and surveillance for reinfection. So if somebody is an injection drug user and you were able to cure them, you may want to periodically check again to see if they're if they have become infected again, and you can do that with serial transaminase checks, or also viral load. Obviously, you will not be able to check an antibody because their antibody will probably remain positive for a while, or forever potentially. And then also for those with cirrhosis, you will need to have, my patients with cirrhosis, I do have hepatology consulting with me on those patients. For my non-cirrhotics, I manage them, but for my cirrhotics, I do have hepatology management, continuing to manage them and help with their surveillance as well. Next, and I think the next slide is the last slide. So just to reemphasize those high points, we need to know everyone's Hep C status, because we have excellent therapy that's available. It's cure, it's short term, it's very easy to treat and well tolerated. It's important in our co-infected patients, particularly because HIV infection is independently associated with Hep C disease progression, and it should be a priority in our population. And if you guys are not aware, most of these slides come from the website Clinical Options, clinicalcareoptions.com, an excellent source for HIV, as well as HIV and Hep C, and then just even Hep C treatment. And it's free. You just have to, log in with an email address, and you can get that information as well. So thank you.
Thank you very much, Dr. Rana. It was a wonderful presentation, and we really learned a lot. So I think we will keep your questions towards the end of presentation. If I hope you'll be staying. Wonderful. Thank you. Just as a few housekeeping steps, I see there are a few questions in question and answer sections, and there are 28 comments in chat section. Unfortunately, when my screen is being shared, I cannot see the chat, what's going on. So if there are any questions, which I'm sure going to be many, please just mention in question answer section. There is a tab very next to chat section. So please just keep detailing those questions in that tab. And our next presenter is Dr. Martha Sanchez. We are lucky to have her. She is an internal medicine and infectious disease faculty member at Alpert Medical School, Brown University, in my neighborhood in Rhode Island. She graduated from INTAC in Dominican Republic and completed her residency in internal medicine at Mount Sinai School of Medicine. She also finished her fellowship in infectious disease at the University of Medicine and Dentistry in New Jersey. She is an attending physician at Miriam Hospital, Newport Hospital, and Rhode Island Hospitals in Rhode Island. Her research interests include HIV care continuum, global health, and tropical medicine. Topic of her presentation is a success story from Infectious Disease and Immunology Center, Rhode Island, about HIV, Hep C, co-infected patients, and successful HCV treatments. I will be sharing, Dr. Sanchez, your slides. Just a minute, please. Please let me know if you can see my screen.
Yes.
Okay, Dr. Sanchez.
Okay, so hi everyone. It's a great honor to be here. Hopefully this presentation will be helpful. And thank you for Dr. Feza Galani for coordinating this amazing lecture series. Thank you. So today I'm going to be talking about our experience here in Rhode Island and the process that we follow to treating our HIV and hepatitis C patients. Next slide. And so to give some context, so in the United States, as Dr. Rana mentioned, the majority of hepatitis C patients are those who inject drugs, followed by individuals that were born from 1945 to 1965, which are also called baby boomers. In 2019, an estimated 16 to 22,000 people were living in Rhode Island with hepatitis C, which is approximately 2% of the population. Of those, as you know, 80% will progress to develop chronic disease. Next slide. And to highlight what Dr. Rana had mentioned, and also, to the importance of treating this hepatitis C patients, which again, the great majority of them can be cured. It's a curable disease. And so here we can see how disproportion is the number of deaths that are attributed to hepatitis C compared to deaths related to HIV and other. Here we can also see hepatitis B, but also 59 other nationally notable infectious diseases. And so being able to tackle something that we can cure that causes significant mortality is very, very important. Next slide. And so the treatment, we have all these strong, wonderful medications, the direct antiviral agents. And one of the barriers sometimes is the accessibility of those medications, either because of insurance or restrictions that the state might have. So this actually varies quite a bit from state to state. We are very lucky here in Rhode Island that the only limitation that is stated is that those patients that have F3 to F4 fibrosis should be treated by a specialist, which is an infectious disease specialist or a hepatologist. But the rest, somebody with F1, F2 fibrosis could actually be even treated by their primary care provider. Other states, next slide, such as South Dakota, have significantly much more restrictions. To give you an idea, these medications are only approved for those that have F3 or greater fibrosis. If a patient has a history of substance abuse or alcohol abuse, they have a requirement that they need to have documented abstinence for about 6 months or more. And also all patients need to be consulted and treated by a specialist. So we see here how to be able to access these medications, and this is as of Medicaid. It does vary from state to state. So in part, the success that I'm going to report for Rhode Island is, impacted by this. Next slide. And so in the Immunology Center, that is part of Miriam Hospital, Brown University, we follow about close to 90% of HIV infected patients in Rhode Island. And we follow the recommendations stated by Dr. Rana, where we not only know we check at baseline, but we check yearly on those that are HIV hepatitis C negative, their status to be able to document infection and be able to treat them accordingly. And so, and in looking at those, the majority of our patients are genotype 1, followed by genotype 3, genotype 2, and genotype 4 is the least common. And so, as we saw previously, this varies in the different countries all over the world. But we are lucky that many of the medications we are able to use to treat all 4 genotypes. Next slide. And so I think the success that we have is that, as Dr. Rana mentioned, we follow our HIV patients, and so these patients, they have a great deal of trust in us. And so I think that because of that, we are the ideal person to be able to treat them, because we are going to, be comfortable with assessing the drug interactions, and so guiding them through, and rather than adding a new piece of the puzzle of somebody that they have to then establish rapport and be comfortable with, and that could potentially affect adherence to treatment. I think that the fact that we try to do something, an approach that's called patient-centered medical home, where we are sort of the center of care for the patient. And so when we treat somebody with hepatitis C and HIV co-infection, it's not only the infectious disease provider that is gearing the treatment, is more a multi-team approach because of different reasons. So we are very lucky to have, close connection with the Department of Health, who is our guidance in terms of, not only in our center, but statewide, sort of like detecting the patients with hepatitis C, the Rhode Island AIDS care organizations that they help to support the patient with any of their social determinants of health that might be affected, such as housing, peer support. So we try to connect all of our HIV patients with these organizations, and these organizations also offer free hepatitis C testing, and also they help to keep the patients in care. The infectious disease provider, which will have already that relationship with the patient, and will work together with other team members in terms of determining, what is the best hepatitis C treatment for that person. Do the HIV medications need to be modified? And so guiding that process. We are lucky in our center to have PharmDs that are ID trained. And so they help us guide in terms of, drug interactions between the hepatitis C medications and the HIV medications, but they also establish connection with the patient even before we're starting to have a discussion about hepatitis C treatment. And they actually help us as physicians to follow the patient throughout their treatment, and even afterwards, providing counseling, answering any questions in terms of adverse effects, monitoring adverse effects. We have also pharmacy liaisons that help us navigate the process of approval of these medications by the insurance company, and so that's very key. It's not absolutely necessary to have that, assistance can also be provided by other team members, just such as a PharmD or a nurse in centers where, a pharmacy liaison might not be available. An HIV hepatitis C nurse, I think this is crucial as sort of the right hand of the infectious disease physician, in the sense that they're very familiar with both HIV and hepatitis C. And again, they assist the physician in the process of, treating the patient, counseling the patient, and the follow-up. Social workers, addressing any issues with substance abuse, with support with housing, with any other sort of barrier that could potentially affect the adherence of the patient going through the hepatitis C treatment, outreach workers, making sure that there's no gaps with insurance during the treatment course. And so again, it's a very team approach that works together where, we're all at the same level working together to treat the patient. Next.
Dr. Sanchez, last 3 minutes, please.
Okay.
Thank you.
And so just to give some numbers, so we have treated about 209 patients. Of those, 200 have been cured. They have achieved sustained virologic response. Only a few, 9, had treatment failure. Of those, some did not complete the treatment. Some had issues with adherence, and some with drug interactions and adherence. We have currently 8 patients that are undergoing treatment. So again, these are closely followed by the hepatitis C nurse and the PharmDs that work together with the physician through the process. And only a minority of patients have not been treated as of yet, either because they're not interested or they are currently out of care. So again, it's very important to have a continuous conversation with the patient and, never give up. And on every visit, try to bring up that opportunity of, highlighting the importance of treating their hepatitis C and curing it. Next slide. And so another big part is, prevention. So all the resources that the Department of Health has in terms of, offering free hepatitis C testing for patients, providing clean needles for those with IV drug use, community-based sites, again, providing hepatitis C testing, providing condoms to the community. And so again, and as we do in our clinic, something very important once a patient has completed their treatment is, continuing to counsel them about prevention to avoid any reinfection. Next slide. And just a final thank you to Dr. Fatah Gilani, who is, also a key member in our clinic, providing, all the data so that we know where we're at and who we need to treat. So she's a crucial member for this effort. Dr. Karen Tashima and Dr. Joe Garland, that also are leaders in our clinic, our PharmDs that guide us through this complex treatment process, our hepatitis C nurse, Donna Nunez, and the entire team at the Immunology Center.
Thank you very much, Dr. Sanchez.
Thank you.
And I mean, it's always wonderful to learn how the teamwork, team effort, and collaboration between different skill sets can be so effective. So our next presenter is Dr. Bushra Jamil, rather Professor Bushra Jamil. We are lucky to have her. She is a wonderful sport and had helped us in all those webinars on a continuous basis, almost on every week. We really appreciate. She is a professor in Department of Medicine in Aga Khan University. She is a professor of medicine, and she is also a national coordinator of Common Unit for Management of HIV, tuberculosis, malaria, and she plays a significant role at not only local level, but also coordination between the care providers as well as the national government. She is so nice, and being disadvantage of being so nice, she's going to get only 5 minutes for us for this presentation. So Dr. Bushra Jamil, Sorry,
Thank you very much.
No
yeah,
worries.
I will only take 3 minutes. So you can project it, or I can share my screen.
I'm going to start sharing it.
Yeah. So I'm just going to briefly recap on history of HCV in Pakistan and what is the current status. So,
Dr. Jamil, if you have your camera, if you can turn that on. If not, that's okay.
let's leave the camera off.
Okay.
If it's okay.
Please.
Thank
no,
you.
That's fine. Yeah. You can go ahead.
So if you can go to the next slide. So if you look at prevalence of HCV in Pakistan, Pakistan has one of the highest HCV infection levels in both Middle East, North African region and worldwide. And HCV prevalence is about 5%. 1 in every 20 Pakistanis has already been exposed to HCV infection. Next one, please. Next. So I added animation, so it's just keep on going. So initial HCV cases were recognized on screening of blood donors in 1989 to 1993. So the first national survey was conducted in 2007-2008. And in this, a total of nearly 47,000 individuals were tested. And the overall prevalence of Hep B in this survey was found to be 2.4%. And that of hepatitis C was found to be 4.8%. But this was way back in 2008. At that time, the highest prevalence of Hep B was found in the province of Balochistan, 4.3%, which is quite surprising because Balochistan has the lowest population in the entire country. So maybe it was just targeted towards high-risk groups. And this was followed by province of Sindh with 2.5% Hep B status. The highest prevalence of Hep C was found in province of Punjab, 6.7%, followed by Sindh with 5%. Next one, please. So this map here shows pooled mean hepatitis C virus prevalence distribution amongst the number of chronically infected persons across different provinces in Pakistan. So according to this data, highest prevalence has been found in Sindh, with 7% positivity for hepatitis C, followed by Islamabad Capital Territory, Khyber Pakhtunkhwa at 6.6%, Azad Kashmir at 5.8%, Balochistan 5.8%, and then Punjab at 5.6%. So the pool mean for Pakistan is 6.1%. Next one, please. Next. So additionally, pockets of high HCV prevalence have been found in Pakistan where the prevalence is up to 22%. Males are more often affected than females, and the major risk factors are increasing age, exposure to therapeutic injections, history of surgeries, hospitalization, blood transfusion, shaving by barbers in the community, being married. All these are risk factors for both Hep B and C. And in a study amongst prisoners in Lahore, the prevalence of HCV was found to be 15%. Next one, please. Next one. Next. So there is an apparent HCV transmission in Pakistan, like that of HIV, is primarily driven by healthcare related exposures, such as injections, IV infusions, and poor sterilization of medical equipment. Injecting drug use and other community-based exposures also play a role, but their relative as opposed to absolute role is probably small as compared to healthcare procedures. Next one, please. So Pakistan is different from the rest of the world because there is a major role of healthcare related transmission in Pakistan, which is in contrast to what you see in other countries. Next one. So transmission is resembles that of HIV. So if you look at co-infections, because of common routes of transmission, it is possible that we have high prevalence of co-infections as well. 2 or 3 of these infections can occur simultaneously. And obviously co-infection leads to greater degree of immunosuppression and disease progression. Next one. So in a study on males who have sex with men, the prevalence of HIV was found to be 11%, for HCV was 23.5% and 8% for HBV. And in this same group, 5% people had co-infection of HIV with HCV. Next one, please. In another study which was carried out, can we go back? Carried out at an antiretroviral therapy center in KPK. This study was conducted over a period of 5 years in 710 patients, and prevalence of HIV with HBV co-infection was 9.57%. HIV with HCV was 6.76%, and around 2.4% had triple infections. Next one, please. So despite the availability of generic direct-acting antivirals in Pakistan and an accompanying reduced cost of treatment, the prevalence of Hep C remains persistent with no evidence of decline. Next. So one of the reasons for this persistence is the absence of a comprehensive population-wide screening program that can identify the missing millions of people who require treatment. But another important factor is our poor healthcare system and the reasons which are driving the HIV epidemic as well. They are still here and we have not taken care of them, like reuse of syringes and unnecessary use of injectable medicines. Next one, please. So our problem is poor healthcare practices. Our at-risk population is not the typical key population which you see in other parts of the world. And we need to have unified implementation of unified control measures. And these can then bring down the disease burden of HIV, HCV, and HBV in Pakistan. Thank you very much.
Thank you, Prof. Jamil. If you could kindly stay online, it'd be interesting to learn from you who is treating, how many specialists are for such a big population of 7 million of HCV and also co-infection in terms of specialists and availabilities, facilities, etc. So our next and last presenter is none but Dr. Abbas, who was kind to be with us last week too. She is again continuing her cases which she started last week. She is a graduate from Fatima Jinnah Medical College in Lahore. She completed her internal medicine residency and infectious disease fellowship at University of Toledo, Ohio. She is a staff member at an academic hospital setting and supervises medical students and residents during their clinical clerkship rotations. Dr. Abbas is infectious disease physician in private practice located in Rockland, Florida. She manages inpatient infectious disease, including HIV positive patients in hospitals, and also follows those patients in her office. Her presentation today is going to be HIV presentation, HIV cases, which she started last week. Dr. Abbas, we have to request if we can stay in terms of presentation being 10 minutes, if possible. I know you were going to take 15 minutes, but if that is a possibility, and you can take the control, you'll be presenting your slides, please.
Okay, sure. Can you share my screen? Can you see my screen?
Yes, we can see your screen. You can go to presentation mode, please. Yeah.
Okay. Hello, everyone. Assalamu alaikum. So we had some unfinished business, I guess, last time. So Fiza requested that I finish off the presentation. So I had one case left, which I wanted to share. So let's begin. So this is a 63-year-old white gentleman, MSM, with history of HIV for about 34 years. And he does have co-infection with hepatitis C, which has also been untreated. He presented to my office in March of 2019, wanting to resume antiretroviral therapy and to get his labs checked. He tells me that he stopped taking his antiretrovirals about a year ago as he read that the combination pill that he was taking was facing a lawsuit as there was concern for bone and kidney issues. He's well known to me, and he was last seen in my office a couple years ago in 2017, and at that time he was undetectable. So this patient, you know, he had a pattern of going off his medications and getting lost to follow-up. And the first time that I actually saw him was in 2015. So apparently he was undetectable until 2013. However, he was hospitalized in 2015 with full-blown AIDS and had evidence of pneumococcal septicemia. And when we did an echo, he had aortic valve endocarditis as well. So that's my first encounter with him. He recovered from that, and I saw him in the office, started him on antiretrovirals. He took another year to become undetectable, but his CD4 remained below 200. So this is an important factor to consider in patients who've had several decades of this infection and poor adherence off and on, that you may not be able to get their CD4 above 200 in some of these cases. Now, he is a former smoker and has emphysema as well. He had an anaphylactic reaction to sulfur, which was an allergy. When I had discussed PCP prophylaxis with him, he refused the Dapsone as there is some cross-reactivity with sulfur. And when I prescribed Atovacone, he didn't like the taste, so he didn't take it. So he was not on any PCP prophylaxis. And as of 1.5 years, he had stopped taking his antiretrovirals. So this is the office visit. So he basically presented with these complaints that he was having a dry cough since about 4 weeks. And he went to his primary care physician who prescribed Levaquin and prednisone for him and suspected that he had a COPD exacerbation. So his dry cough is persistent, and he reports that he's having increasing night sweats and he's lost about 5 pounds. And now he decided that he wanted to check in with me again to establish care. He just reported some dizziness and some low-grade fevers, didn't really report any significant dyspnea. On exam, he was 99.2, vitals were otherwise stable. Chronically ill-appearing temporal wasting, oral thrush on exam, no lymphadenopathy in the neck or axilla, lungs were clear, there was no skin rash. Question: what is the most important next step? Number 1, order chest X-ray. Second, order CBC, CMP, CD4, HIV viral load, HIV genotype. Order hepatitis C viral load. Start a different antiretroviral therapy than the one the patient is concerned about. All of the above. And finally, my favorite, none of the above. So of course, the answer is none of the above. So we checked his oxygen sats, and he was saturating at 79%, and he was directed to the emergency room. So, you know, in the world of COVID, we have a term of happy hypoxia. So if you want to extrapolate from that, if you see a patient with HIV/AIDS with a subacute chronic dry cough, please don't forget to check their oxygen sats. This is a very small and simple message, but you can imagine that we had to hospitalize him for the oxygen that he was requiring. Recognize an opportunistic infection and prioritize its diagnosis and treatment before you get back to the HIV management. So remember this, PCP is always fatal, untreated. And even if you give them the right medications, there's 15 to 20% mortality in hospitalized patients. His blood gas showed a PO2 of 61, which is less than 70, which qualifies as severe PCP. CT chest was classic. It did show severe emphysema, a right upper lung nodule, but bibasilar interstitial and alveolar infiltrates consistent with multilobar pneumonitis. And in the world of COVID today, this can look exactly like COVID. Marked splenomegaly because he has untreated hep C. So we did an induced sputum. There were numerous fungal spores and hyphae consistent with candida, but negative for pneumocystis. So this in itself suggests, because he had thrush, that the sputum specimen was likely contaminated. Because of his emphysema and because he was requiring high flow, the pulmonologist colleagues on the case said, we will defer the bronch. We don't know if this gentleman will get extubated if he does deteriorate. And therefore, I did not have the luxury to have a bronch specimen as well. So we went ahead and did more workup that did not come in time. The viral load came back later. It was 51,000. He was definitely still full-blown AIDS. CD4 was 17. He was pancytopenic. LDH was elevated to 44. So in a patient with an anaphylactic reaction to sulfur, the second option, which really works really well, and I was talking to Dr. Naseem last time, and she said clindamycin and primaquine really is a good regimen. But over here, dealing with a few malaria patients, we really have trouble getting primaquine in the outpatient pharmacies. So just because of those practical reasons, I don't have that as a second choice in the county that I am practicing. So we went ahead and put him on pentamidine IV. And because he was hypoxic, if you don't use steroids, they will get worse, especially the hypoxemia. So you have to add prednisone. He was on a high flow nasal cannula, 40 liters, 100%. He took about 4 days and then he started getting better. And he was discharged to a long-term acute care hospital to complete his 21-day treatment course. And he did well. I did not continue to take care of him because this was a gentleman who had issues with compliance, who had issues of a 30-year-old illness. So one very important, because I understand there are a lot of general practitioners also seeing these webinars. I am an infectious disease physician and I see cases of HIV, but I also need to know my limits when I can help a patient and when I think they will benefit from a more dedicated, comprehensive HIV clinic. So I referred him there. And I also don't treat hepatitis C. So it would be best to collaborate with those physicians as well to get his Hep C treated. A few pointers and then I'll end quickly. So, the thing is, there are not so many infectious disease physicians in Pakistan. So all general practitioners, if you have HIV patients, whether they are treatment naive or treatment experienced, if they are following up in your office, if you can detect a problem and facilitate the care to the infectious disease physician, it's always good to have more eyes on these patients. So when you do a review of systems, do look at a weight trend. No matter what they say, they are fine. If they've lost 10 pounds, they have a problem. Ask for night sweats, fevers, fatigue, rashes. Some patients will have vision problems. Get an eye exam every year at least. And especially if they have a complaint, if they have chronic diarrhea, just think, is that related to his HIV? And even if they tell you they're taking their medications, you do not know how well they are taking it and how adherent they are. So you may have clues about other things. Always go back to this diagnosis. Is it related? GI, diarrhea, pulmonology, any chronic coughs, any neurological complaints, a lot of them can get neuropathy, things like that. Always check the SATs if you're dealing with respiratory symptoms, check their weight, look in their mouth, check for lymph nodes, do a skin exam. Also, the longer these patients are living, the more we are noticing that, HIV does accelerate atherosclerosis. So their cardiovascular risks may be what kills them. It may not be the HIV. So you need to kind of try to improve this, find out their family history. Are they smoking? Hyperlipidemia, control their diabetes. I have lost patients with uncontrolled diabetes. They just can't handle the opportunistic infections and they don't do well. Medication tolerance. If they're not taking their medications, if there are issues, send them back to the ID physician. They are getting labs every month. Ask them about them. Do a vaccination review. They don't have to go to the ID to get their flu shot, to get their Hep B, Hep A vaccines, and do an annual syphilis, TB, and STI screen. And if you are dealing with a woman, a pap smear. So consultation and collaboration with an experienced infectious disease physician who is trained in HIV is strongly recommended for better patient outcomes. Thank you so much.
Thank you very much, Dr. Abbas. Appreciate. I think it is about 1 hour, 10 minutes. We will stay for another 10 minutes online just to answer a few of the questions. And thank you for all the moderators and presenters. You have answered most of the questions already, but just for audience, there may be some repetition. But I think for people who might not have seen those written answers, I think maybe we can ask, or we can also add a few new questions. I think for Dr. Rana, Dr. Hisham had asked about the stigma, social stigma. Yes, I think social circumstances are going to be different in Pakistan or developing world, especially Muslim world, compared to what we have, the barriers and implications and social isolation. resulting from all those diagnoses. But I mean, any suggestions how people can counteract them? How can they educate their patients being a physician?
Yeah, no, completely agree. As I typed in that response, I mean, there are, it's HIV stigma is prevalent everywhere. I live in the southern part of the country in Alabama, which is very conservative, also very religious, a lot of stigma. I have so many patients that I am the only, our clinic is the only group that knows that they have HIV. Nobody else knows, and it's very tough. So, we don't really have a lot of interventions, geared towards stigma. We're talking about a lot of society needs to be educated. People need to, there's what we call externalized stigma. So that's the stigma that you experience, from other people. There's internalized stigma, so your own internal stigma that you feel after, either being at risk for or having HIV. And then I think the more complicated thing is all of the intersecting stigmas that a person may experience. So when we think about the people who have HIV, often we are talking about marginalized communities. So whether we're talking about injection drug users, whether we're talking about poor or economically disadvantaged individuals, whether we're talking about people of different genders or transgender or people with different sexual preferences. So I think as providers, we have to come with a lot of empathy to the table and recognize that people are experiencing all of these things in one, and that's their daily life. And so I think compassionate care, informed care in that way. And I think always as providers, we have to be champions for them. So pushing our medical authorities, pushing our health authorities for campaigns and education. But I think not just for the general public, but I still experience stigma when I talk to my providers in other specialties about HIV. So some of them still have a very antiquated view, and so I think forums such as this are important because you have to get to the healthcare providers as well, and then I think really a lot of education in the community. So we don't perpetuate the exceptionalism of HIV, but just as we want to recognize diabetes, just as we want to recognize hypertension and cardiac disease, we want to recognize and treat this as well. But it's going to be a journey, and it's going to very much take an all hands on deck approach.
Okay, thank you. Sorry, this question was from Anayatollah Memon. The question from Hisham Haq is for Dr. Sanchez, and maybe we can also take advice from Prof. Bushra Jamil after Dr. Sanchez. If somebody had to learn and replicate a practice model like Rhode Island Center, what's the advice?
So I would say the advice would be, again, to try to have a team approach, depending on, this is going to vary depending on the personnel that is available to each center, because obviously, each center has different resources, but, have not just, try not to have all the treatment, focused on the physician, but also the support staff. And so that would require training the support staff and, sort of coming up with like a team where everybody, let's say, is assigned a different part of the treatment, particularly around, support before, during, and even after the treatment of the hepatitis C. Because, again, these drugs are wonderful and amazing, but we know how having 100% adherence when they're actually, going through the treatment is key for them to be able to achieve that sustained virologic response. And so, again, in our clinic, having the nurse, establish and the PharmD start a relationship before, so that they develop that trust with the patient, and knowing that they can reach out, whenever there's something like a questions comes up, either before, during, and after the treatment, so that, we're helping them make those decisions in terms of the person being afraid and, deciding not to do the treatment or stopping the treatment in the middle if they develop some sort of side effects. So again, identifying staff in your clinic that could help support it and training them and, just working together through the process.
Wonderful, thank you. Dr. Jamil, maybe you can expand on the same theme. I mean, if you have to work on similar model, I'm sure you have kind of similar models in your setup, but you're in a very good setup. But overall, if you talk about Pakistan, who is the best candidate? Are they the government institutions or the non-profit hospitals? I mean, I believe it's maybe difficult for a private setup or a smaller group to come up with such a decent setup of collaborating with the pharmacist, with infectious disease specialists, gastroenterologists, nurses. What do you think?
Yes, so at the moment, the private tertiary care centers are the only centers which are capable of providing this kind of service, where you have trained pharmacists and good quality nursing staff and properly trained physicians who can give quality clinical services. But what we are exploring at the moment is to identify few sites where you have willing team of physicians who can work with us and create what is called a one-stop shop solution. So this idea came in from the TB and HIV programs, whereby we can offer the services for these infectious diseases from one side, along with services for non-communicable diseases as well. So we are working on this concept and trying to replicate the model at a few government facilities. So it is in very initial stages. So once we start implementing it, I will come back and share my experience with you all, but this is the way to go.
Okay. Another question, maybe we can continue with you. It was scary, not scary, rather horrible to see more than 90% of IV drug users are infected with Hep C or HIV. Am I right looking on your presentation?
So IV drug users have high prevalence of hepatitis C and B as well, but it's the general population. If you remember my presentation on HIV in the first of this series of webinars, actually the general population has been badly affected by HIV, and along with that, HCV as well, and Larkana is the prime example of that. So we have 3 hotspots of HIV in Pakistan: Gujarat, Sargodha, and Larkana. And I believe the prevalence of HCV and followed by HBV is also high in these areas, because it's not the commercial sex workers or just the IV drug abusers. IV drug abusers do have a high prevalence, but all of this is spilling into general population because of poor injection practices and unscreened blood transfusion and use of unsterile equipment, and barbers. Actually, the role of barbers has been identified repeatedly because they use sharps and reuse it without sterilizing them. So the viruses are transferred from one client to another. So it's the general population which is at risk. And that's why Pakistan is unique among countries, because it's not just the people who indulge in high risk activities, it's the general population which is at risk.
Okay, thank you. Sorry, we keep asking you more questions. Actually, we're trying to learn from you based on Pakistani experience. Now, I think next question is very important, clinically relevant, as well as quite a significant issue for families, I'm sure. For people who have a family member who, it may be husband, it may be brother, it may be father, or whosoever in different relationships, obviously different exposure risks, whether HIV or Hep C positive or maybe combined. How the family members and loved ones and people around, I mean, do they need to take precautions, and what kind of precautions? I think I can start from Dr. Abbas, then we can go to Dr. Rana and come back to Dr. Sanchez. Dr. Abbas, your microphone is off. Yes,
yes.
Okay, so I think I'm going to let Dr. Rana and Dr. Sanchez address the HCV. Now, from an HIV standpoint, I think I had discussed in my previous webinar about the potentially infectious and the non-infectious fluids when you're dealing with. So, if it's a husband and wife and they are HIV discordant, for example, the husband is HIV positive or the wife is HIV negative, then they have to use protection during sex. So that is number one. Number two is, as far as any bloody fluids or cuts or open areas or injuries, in that case, they just need to be aware that if there is a bleeding wound or anything, the person who has HIV needs to wash it immediately and keep it covered. Other than that, the other bodily fluids that we had discussed, you can share the same toilet. You can, there's no, I know that there's a lot of stigma and isolation that these, especially children, are, isolated from the rest of the family. You can eat with them, drink with them, hug them, kiss them. There's no precaution needed as far as HIV is concerned when you're living with your loved ones. There is no transmission reported from this. So just being mindful of the blood and the bloody bodily fluids. If there's any incidences or evidences, then you can wash your hands. And I'm sure the discordant couples should be going to a physician to get tested for HIV. And if your spouse has HIV and if they are undetectable, then it is considered untransmissible. So, again, you need to discuss with your infectious disease physician regarding how you're going to live together. But we need to love these family members because the world is very cruel around them. So have an empathic heart, and may Allah protect you all.
Thank you. Thank you. Dr. Anna, you want to add?
Yeah, so I would say that the same as Dr. Abbas has so eloquently stated, a lot of the same principles are applicable for Hep C as well. Hep C is just like HIV in terms of blood transmission. You need to have that transmission. So household transmission is going to be an extremely rare event. So, and I think Dr. Sanchez mentioned this in the chat, so you can bleed from your gums. So you don't necessarily want to share toothbrushes or razors that bleed. In terms of sexual transmission, heterosexual transmission is really rare. In fact, previously our paradigm was we didn't think Hep C was transmitted sexually, but when there's blood involved, there can be transmission. So men who have sex with men, obviously are at risk in that setting. And so that's why we particularly target that population in terms of screening as well, because they can have traumatic intercourse. But as Dr. Abbas said, nothing else. You're there in your home, they're part of your family, they can share everything else. And certainly, if you're aware, an opportunity to get engaged in care and look at opportunities for treatment.
Okay, thank you. Dr. Sanchez?
Yeah, I think not much to add. I think they have covered, the main things. But again, I would say outside the household, something that has had, a great impact in terms of, health departments and, the public health system is sort of remove a little bit the stigma for IV drug users and have, needle exchange programs. I think that's something that has had a great impact here in the US, so that, as we see, sort of like the great driving of this sort of epidemic is, IV drug use. And so having needle exchange programs and removing a bit the stigma on that, offering support for treatment of IV drug users, but also having those exchange programs and, having them readily available, also, helps significantly, decrease this epidemic.
Okay, thank you. I think I would like to add, yes, I'm not sure how much culture, even by practitioners have changed or how different it is. but there is no bashing for those patients. I mean, they come in, even if they relapse. Okay, we are here to help you. I know it happened, but it's okay. It happens. We will take care of you. So that's attitude I think we have here most of the times. And I think that helps. It keeps those patients in the healthcare system rather than disconnecting them also, rather than kind of they just walking away. I mean, if they're not going to follow, they're not going to follow. There are going to be times when they will drop off the scene. But if we are good to them and if they know we have a kind of caring team, they will come back. Maybe not today, tomorrow, day after, next week, they will. But it's always better to be in a healthcare system for them rather than to be on the street buying and dealing with drugs. Agree. Thank you for that. And Dr. Jamil, I think maybe last 5 minutes, rather 4 minutes, we'll be closing at 9:30 Pakistani time and 12:30 our time. So in terms of another purpose of these webinars was also to show and kind of to just give the idea, these things can be treated by people of different backgrounds, different specialities. It is not kind of I mean, in my field, I mean, we work collaboratively in vascular medicine, intervention radiology, cardiology, vascular surgery. So, I mean, all of us have a role to play. Similarly, for HIV and Hep C co-infection, I think there is a very significant collaboration which needs to be between especially ID doctors, primary care doctors, hepatologists, gastroenterologists. But in Pakistan, what's the kind of, I mean, you said you have about 7 million people for Hep C. How many specialists we have from different specialities who are taking care of those patients or who have potential of taking care of those patients? My concern is going to be many procedural specialties are already so busy with treatments, with procedures, with interventions, how they are left with the time to treat those patients who are only medically treated.
So I would request Dr. Huma to comment on it. She's an eminent gastroenterologist, but I will give you my opinion on this. So this is a turf issue and all the programs are vertical. So nobody likes to talk to the other specialty and there is very little collaboration. And whatever there is, it's very limited. So that is one problem. Second one is that the centers which are offering treatment, for instance, there was this hepatitis C program which ran for a short period of time, and this was initiated by the Sindh government, but then had to be stopped because of funding issues, and that was primarily being run by family physicians and guided by gastroenterologists because they were given very simple guidelines for treatment and it was working out well. So those are the kinds of programs which should be sustained and expanded. So, and we need to actually break the verticality of the different programs and start collaborating. And then this should go hand in hand with training of family physicians, simplifying guidelines, adapting them to the local conditions, and empowering general practitioners actually to provide the first line care, ensure screening, and so on. And then there should be a proper system of referral. So all this needs to be done. And I'm doing a little bit of work in actually breaking the verticality of TB and HIV programs in Pakistan, because that is absolutely essential. A large proportion of our HIV patients are either have tuberculosis or at risk of developing TB. So how can you run a program vertically without talking to your colleagues? So here comes in the concept of one-stop shop, and the same holds true for these other bloodborne viruses and hepatitis viruses as well. So I would request either Dr. Huma or any of the other gastroenterologists who are attending this webinar, and they can comment on how many gastroenterologists we have and what kind of services they are providing.
I think we will have to check with Waleed. Waleed, can you add Dr. Huma as a moderator quickly or turn off her microphone so she can have her say? I cannot. Yes, we see Dr. Huma. Please turn off your microphone if you could kindly give your opinion.
Hello, Muzammil, can you hear me?
Yes, I can, please.
Thank you. Thank you, Muzammil, and thank you, Fiza, and all the colleagues for a very wonderful, talks. Yeah, Dr. Busha has very well said that, the infection in Pakistan is generally in the general population. And this general population are like common people who are suffering from Hep C. And our guidelines very clearly state that the treatment should, for non-cirrhotics or people with F1 and F2, can be treated by the general physicians or the primary care physicians. So the question of linking patients who have F3, F4 or people with HIV, the HIV prevalence is very low. In the general population, it's 0.002%. So it's a small chunk of people who would require a real, coverage by the internists and the, internal medicine people and the hepatologists and the HIV group. So by and large, we in Pakistan need more of the primary care physicians to look after these patients. And the guidelines are so simple. We have genotype 3, the drugs are available. We have soft DAC, which is working more than 95% efficacy, with followed by soft well. So we generally have no issue, except the issue is that there's a huge population of almost 8 million people who need to be screened and tested and treated. And that is being done through the Prime Minister's program, which is being launched in the next few weeks. And hopefully, inshallah, this will go over the next 10 years and will cover all the population. And by 2030, the targets as calculated by the CDA, Homi Razavi, that by 2030, we should be able to clear this infection from Pakistan. Thank you.
Thank you. Appreciate. And I also want to especially thanks Dr. Gilani and Fiza Bhabi Fiza, that we'll be coming up with those lectures, HIV 121, 101, as well as for Hep CV. I think that's what we have seen in United States. More and more care for those simple HCV patients is provided by, we call them primary care physician, you call them general practitioners, same thing. And I think it needs to diversify if we really need to treat so many people. Keep an eye on our YouTube channel. We will advertise here. We will probably simplify the name. And with that, Dr. Gilani, is there anything you want to add before we adjourn?
Yeah, I would just like to thank everyone, and please realize our webinar series were designed based on this realization that we need to start talking at healthcare providers level and discuss with each other. And thanks everyone to learn us more about Pakistan and learn from each other. Thank you again for attending.
Thank you. And more than organizers and panelists, yes, thank you, panelists. We appreciate, but also with special thanks to our participants, to people who spared 1.5 hours to listen to us. And at one stage, we had almost 100 people. That's wonderful presence. Thank you, and have a good night and good afternoon, everybody.
Thank you.
Thank you, Dr. Muzammal.
Thank you. Thanks.